Good morning. This lecture's on quality assurance and radiation therapy. Some of these are George's slides, but I managed to inject a few of my own. So I think, George, you'll be putting this on the website, right? Okay. I took this slide from George's presentation. The purpose of this presentation: make aware of the needs for quality assurance in radiation therapy, identify components of a quality assurance program in radiation therapy, and identify some of the quality assurance criteria in radiation therapy. And George tells me that you use Khan as your textbook, and the QA section or chapter is pretty good. So I would certainly refer to that for numbers that you need for your boards, essentially. So some general comments of my own. Routine QA testing is repetitive by nature, and can be somewhat dull. However, it's been my experience, it becomes very exciting when you find an important problem. And often this is during routine testing, but not always. So sometimes a mistake in QA is going to pop up in a different way, and it's brought to the attention of the physicist. And just some general philosophy here is physicists must have suspicious minds. So that's our job. Our job is to when we go to do QA, we don't want to be complacent. That's a very bad characteristic to have. When I was taught, my clinical training was at Memorial Sloan Kettering, and I was taught that when you approach a QA task, you look you assume that there's something wrong until you find out that everything is right. So we always try and look for things that are wrong. So as I said, we can't become complacent. And the number one thing about QA is that redundant checks are necessary. So this is from George. What's important? Small deviations, probably unlikely to injure the patient or even be noticed, and that's absolutely true. So the real problem is when large errors occur. And George has listed a few things here, and these are probably, I recognize these almost directly from some large QA problems that have happened in the distant past and in the not too long ago, last year or the year before. So let me, I always like to start out a QA lecture by showing you a couple of those very serious QA errors that happened that have led to life-threatening impact on patients. So you may be aware of some of these. This is one that happened in 2005. This is an article out of a newspaper in Florida. And this a problem that happened at Moffitt. There was a medical error discovered. 77 brain tumor patients received incorrect doses of radiation. You can see there were 50% more radiation was given than intended during a procedure known as stereotactic radiosurgery. So the background to this was a new machine that was installed, and maybe you can't read that, but it says incorrectly calibrated by one of the hospital's medical physicists. So I don't like to see that. We should try and keep our name out of the paper. And obviously they've drilled down enough to figure out that a medical physicist made this error, which is pretty unusual. In any time that I've been an expert witness, normally these cases they're totally unaware that a medical physicist is even involved in the treatment, and the radiation oncologist is usually the one that's fronting these type of articles, I guess. So this is, I don't know if that's a good thing, equal opportunity for us, but we have been identified in the newspaper. The background of this is a new machine, and as is common now, we use spreadsheets, to Excel spreadsheets. We used to do everything by hand or slide rule. And to calibrate the machine, and there were some incorrect entries in that Excel spreadsheet that weren't caught until actually the RPC visited and picked up the error. So this actually could have gone on a bit longer, except that they had an RPC visit within the first year after treatment. So what didn't happen here, I think, were redundant checks of a a newly calibrated machine, basically.
So when you say redundant checks, how often?
Well, especially a brand new machine, maybe you want to get, some independent TLDs sent in. And this is a smaller place, maybe with some new staff. So bringing in, TLDs, for instance, or have a second person come in and double check their calculation, or start from the beginning and do it by hand and figure out why aren't these two numbers matching. I would have at least done those type of things. What do you think, George?
Well, I have a friend whose medical physics practice consists of doing loadings. So the first thing he does when he goes to a new site is he contacts Marilyn Stovall here in our department, who runs a TLD service. And he just has a bunch of TLDs brought in. He checks them out just to make sure that the dosimetry that was done prior to his coming to this site is valid. So yeah, I think the TLD is probably one of the easiest ways to do an independent check.
Yes. And I had one friend who was in a solo practice, and he was getting a new machine. He asked me to come out and review everything that he had done to try and pick up any mistakes that were made. So I think that's also a good idea. Here is an incident that happened in 2001 in Panama, and this occurred with a treatment planning system. 28 patients were, and again, this was a new treatment planning system. Perhaps it was not thoroughly checked out. Patients got from 20 to 100% over the prescribed dose. So obviously, if you make a mistake that they're getting less of a dose, perhaps that's not going to get picked up right away, or it's less serious. But the overdose is certainly what happens. Is 9 of the patients died, 5 were attributed to radiation overexposure. So this is 2001. I haven't seen much update, actually, with the rest of the patients.
I think the problem in this case was the order in which they contoured blocks into the treatment planning system, and the order in which points were contoured had some effect on the actual calculation.
Yeah, I think what it was doing, it was making what you wanted to be open was actually blocked, but there was no visual display of that, and so it was giving a wrong. It was giving like these much larger monitor units instead of the correct ones. But again, that would have that's lack of treatment plan verification. So the machine was brought in, plugged in, did some beam fitting, and there was no verification done to make sure that the treatment planning system was acting correctly or they were using it correctly. And as George said, the method of entering the beam block data was really the main problem. But again, it's always good when machines come in of all kinds that they're not just wheeled in and plugged into the wall and turned on, and maybe they were commissioned by the manufacturer, but there always needs to be a check afterwards that the use of the system is being done correctly. And then this is a classic story from the 70s. It says the first serious accident, maybe there were others, but this was at least fairly well documented. So a wrong calibration due to the error of cobalt-60 half-life caused the overexposure of 400 patients, that says 426 patients, and their doses initially started out at a lower overdose, but gradually increased with time. So there was an error in how the cobalt-60 half-life was being decayed by the physicist responsible for calibrating that machine. So again, this is a funny QA issue because cobalt obviously decays at a certain rate, and you would just assume it's being decayed at a certain rate. This person did not do any monthly output check, for instance, or even yearly. It must not have been going on to check that how they were doing this by hand, this automatic decay, were they doing it properly? So in other words, you kind of get into this complacent mode where you're just assuming you're doing everything right, and what's so hard about calibrating a cobalt machine? It should be relatively easy. And so there was a paper that was published in the Red Journal in '95 that actually was a follow-up to what happened to these patients. And this is essentially what happened. Initially, the calibration was correct, but the way they were decaying, the way this physicist was decaying the activity became more and more incorrect over time until eventually there was a 50% overdose of patients, and they started to see complications in the clinic. And so here's this paper, Radiation Overdose Incident Initial Data. And again, that's a pretty good analysis of all the complications that happen. Among the 183 patients who were still alive 1 year after treatment, more than a third had severe complications of the central nervous system and the GI tract. So again, from what they could get, they took a look at the relationship between dose and these complications that were happening. And I have a copy of the paper handy here if you want to take a look. One of the things I didn't mention was an incident that happened in 2006 in Glasgow. And that was a patient, I think it was on it wasn't on a Gamma knife. George, do you remember? This is the report, and I just printed out. And this is a patient that received 58% higher dose than it prescribed, and she died because of her complications.
It was a young woman, I believe.
Yes, right. And this is the Scottish government investigated the incident. It was a series of QA problems, including mistakes were not caught at chart check time, which should have been. And the patient received 19 of their 20 treatments before the problem was found. So she was severely overdosed, and then the Scottish government investigated the incident, and here's the 100-page report. And it's very clear. It certainly can be found on the web and such, but this was a clear failure of QA practices and redundant checks, actually. Again, I think it's sometimes we have this mindset of being complacent and not looking for something that can go wrong.
What disease site was treated?
It was her brain, and I think it was her brainstem that got severely overdosed. Yes. And that's likely to be when there's a big problem, it'll be caught when it's spinal cord dose or GI, that type of thing. Yeah. There's actually a website in Europe. It's called ROSIS, short for Radiation Oncology Safety Information System, and people can voluntarily submit their safety information to this website. In this country, we have a website in the FDA, so if there's a QA incident that happens, we would report it to the FDA website. However, in this country, litigation is rampant or king, whatever you want to say, whereas in Europe it's probably much, much less so. So if you go to this website, they've actually made it a searchable database now that you can, you can look at QA incidences in detail. People are more likely, I think, in Europe to report their problems. So this is George's advice: avoid large errors. So certainly we want to incorporate redundancy, and what we've learned from those instances that I've just mentioned, an independent check seems to be one of the most important things. Always suspect computer calculations. You want to check accumulated dose. You want to check machine output. And you want to check machine output whenever alterations or repairs are made. So these are good words to live by. And physics plays a very large role in the QA that goes on in any department. So segue into the next section here. We are regulated as to what QA we are required to do by law, but state-to-state regulations can vary. And for the most part, state regulations are very limited and sometimes very vague. Some states are better than others. And AAPM, our physics society, along with several others, we must provide leadership on QA guidelines. So everything that you'll see in CON is pretty much has come from the AAPM regulations. And these are the two main task groups that we follow for QA, Task Group 40. See, that's back in 1994, starting to get ancient. And this is Task Group, this is a more recent one for CT SIM, for example. What I didn't mention is there's also a task group that has come out for treatment planning systems. That's 53.
53.
Yes. So the idea behind, and by the way, there's dozens more of task groups out there that have something to do with QA. So every time a new technique comes out, a task group will develop eventually that lays out guidelines for QA.
I want to point out that the task group reports are available to the general public on the AAPM website, www.aapm.org. And you filter through the website, and it used to be that they weren't accessible to the public, but now you can download them. And maybe I'll put a couple of them up on our website.
Okay.
To a couple of them on our website.
Yes, and eventually they make it to the state law, where they'll just say, you should be following TG40 or its equivalent or something like that. So eventually some state regulations will just directly quote AAPM task groups. So we have to be careful what we put in those task groups.
Task groups try to develop what we would call good standards of practice, what's good practice. And I think to some extent we don't want that to be interpreted as regulation. But states sometimes have other ideas.
Right. And yeah, that's one reason why the test groups are public, is so regulators can also keep up to date, I guess. So the general idea is, well, this is for a linear accelerator, but it can go with any types of pieces of equipment or processes or other technology we bring in. Essentially what we do is a new machine comes in and we do an acceptance testing. So the manufacturer actually owns the machine until all that it's installed and all the tests are satisfactory, and then the institution accepts the machine. And then we do some more testing for a couple weeks after that. We take some beam data. I assume we still do that at MD Anderson, right? Although we try and match machines that come in as far as Varian is concerned.
Varian is actually very good about being able to generate reproducible machines.
Yes, yes. So actually this acceptance testing and commissioning of a machine used to take sometimes 3 months or more after we got the machine. And now it's been, I think it's greatly shortened because you can buy matched machines essentially. So
The other thing is that in some cases, the vendor will allow you to do some of the data acquisition at the factory before the machine has even been delivered. So you can go in there, acquire the data, and then just do, once the machine is installed and accepted, you can do some spot testing.
yes, and you get a trip to California to do that. Actually, they're moving to Las Vegas
And
pretty
California's
soon.
expensive.
Putting some bunkers in Las Vegas.
Where would how would it happen that during commissioning the new machine, it would be miscalibrated? It seems like here there's multiple checks and balances. The company would have their physicists manage and then with this. I'm not saying it hasn't happened here, but like that other example you provided.
Actually, the manufacturer won't calibrate the machine. Well, they have some rough equipment and they'll try and get it in the ballpark. And then, you know, our physics team would come in and we're going to calibrate it according to an APM protocol that's called TG51. And so that, what happens is, in the old days, we kind of do it by hand, I guess. And so you could you would see exactly how things, how you're putting them into an equation. And you would have somebody double check everything. That's how I'm used to working. So that other incident that I mentioned, you know, they built it into a spreadsheet, and sometimes that's easy to, you know, have that cell in the Excel spreadsheet is being flipped, or it's off by a decimal place, or something like that. And so that in that case, they did not do a thorough. They didn't do any redundant checks, and so they thought they had a certain output per minute, and it wasn't. It was 50% higher. Yeah. So yes, you would. So a smaller here, you know, you would hope that we have lots of people, and it's more likely we're going to have double checks, and maybe the RPC will come in and also it's easy for them to come in and double check things for us. Would you say, George?
Yeah, I'm not sure exactly what our procedure is now for commissioning, say, in the LINAC. Certainly, if we're doing our annual quality assurance, if any value seems out of line, we would naturally raise a flag on that. But say a TG51 calibration on an annual check, I don't know what kind of redundancy we have on that.
Other than that, we have RPC TLDs
Yeah.
every year.
Yeah.
Right. And so once we do acceptance testing, and these are well laid out list of tests that we do, it's pretty much something that we would do. It's like doing an annual QA test at acceptance testing time. So we just want to ensure, we develop a program to ensure that the machine is still acceptable. And that's This is what our QA schedule looks like, daily, monthly, annually. And daily, you want to test what could be the most unstable and or the most critical, would have the, if in other words, parameters that would change. If they were to change suddenly, they would have the highest impact on the patient's treatment during the day. The annual tends to be, it's unlikely to change over the year. And there are some monthly tests that we do. For instance, we check output in much more detail during the month than we would on a daily basis. So we don't want to just test the output once a year. That would be not frequent enough. So we try and cull down the number of tests that we do on a monthly basis that again are the most crucial. So what to check? Mechanical parameters, radiation, imaging, measurement equipment, and safety procedures. So I'll go over briefly. This is from TG40. This is essentially what we check daily, including, I think we do some field side checks also. But you can notice the most important thing is a device that's used to check the daily output. That's one of the most important things, and that the lasers are also, haven't drifted off overnight. I'm not sure that people use ODIs too much anymore, even for treatment. So, but certainly these safety interlocks are extremely important, and most of this is dictated by the state that we're required to do by law. And here's some monthly, again from TG40, we pretty much follow. We have some mechanical checks that the light field and radiation coincidence are, that when we shine the light field, that's actually where the radiation is not being steered off on an angle, that they're coincidence. That all these mechanical indicators are correct within a degree, so on and so forth. These are all things we check. And then on a monthly basis, we do a more detailed output check of the dosimetry, including taking a look at what you would call some characteristic of the depth dose of both photons and electrons, and making sure that the beam has stayed uniform throughout the month. Things you need to know for your boards, I think they still ask probably a frequency that you check certain things, and what these ballpark numbers are. So there are things you just have to commit to memory. Some of it's common sense. 2% or less is what we're looking for many things, and 1 or 2 millimeters is what we're looking for mechanical type things. And then this is the annual. First we do mechanical checks. So these are much more detailed of the stability of the mechanical parameters of the machine. And we get our big water tank out to essentially scan the beams to make sure they're being steered correctly. And then we check all of this extra equipment to make sure that it's also has stayed stable over the year. These very machines actually are compared to the past, these machines have stayed extremely stable, even over a 10-year period. Once they start to get a little bit ancient, which means 10 years plus, things start to go wrong, things start to go out of spec. So we tend to spend more time, I think, on older machines.
What's the expected life?
Well, it used to be 10 years, and then like hoses start to spring leaks, and mechanically it starts to getting machine sag and that kind of thing.
that point, then you just replace it as opposed to trying to keep it.
Yeah, it's because you start to have more downtime, which is, in this clinic, doesn't matter as much. But when you're at a place that has 1 or 2 machines, it really has a high impact. And you can keep things patched up if you replace some items like the hoses. But eventually, it's, there's machines out there that are probably 20 years old, I would think. But they start to have a lot of problems.
Probably when you're planning your department, think in terms of purchasing a machine and having it last 10 years. Amortize the investment quickly, and then just plan on buying a new one after 10 years.
Yeah.
Part of it's peace of mind. You can't make any money on a machine that's down.
And well, in these days, a varying machine's $3 million. So, they aren't cheap, that's for sure. But you probably make your money back pretty fast.
Years, yeah.
Yeah. So I was just going to show a couple examples of the mechanical aspects of the machine, some of these yearly checks we do. The radiation aspects of the machine must coincide with the mechanical aspects. So that's one way to look. I kind of look at the mechanical as a surrogate for the radiation. So we can't see where the radiation is unless we take some films. So we want to make sure those two are lined up, basically. And I think these are probably pictures from Con. But these machines, everything rotates around one point in space, called the isocenter. And this is one method, probably most common method of checking the mechanical rotation of this machine is still is rotating around this one point in space. Now, this is the rotation of the collimator, the gantry, and the table. It's not there's not a zero tolerance to it, but it's essentially we try and keep it within 2 millimeters. It's usually the couch that's the first to go because the couch is the most abused during the day with heavy patients. Can throw these tables out of spec, and particularly with especially when you're rotating the couch around the turntable, eventually that gets some wobble. These couches have improved also over the years, I think. So we have some tests that we do to make sure the mechanical isocenter stays within tolerance, and this is done on a yearly basis. Once we know that, we do these, what we call spoke shots. And so, for instance, we narrow the collimator and putting a piece of film in a between two pieces of solid water, and we stand it upright, and we're shooting a narrow beam around with gantry rotation, another time with collimator rotation, and another time with couch rotation. And what they should show is these all converge to a point in the middle here. And actually, I usually bring films. I didn't do that. But if you blow this up, you can see these all intersect at some point in the middle here. But you could take a look. You can see these aren't, it's more of a little bit of a star pattern in the middle here. And so we try and measure the greatest distance and where these intersect in the middle. I'll have to blow that picture up next time. And so the most crucial thing on a yearly basis is looking at X-ray beam performance. So we want to make sure the energy of the machine stays the same as what the data is in the treatment planning system. We want to make sure that the beam is coming out flat. And And we have some specifications for this. And again, this is usually on your boards, what these numbers are. So we want to make sure the beam is flat and symmetric. So those are two different things. Whoops. And again, I think this is from Kahn. So the center of the beam, looking at a beam profile across the field, we call it 100% in the middle, but we always, because of the flat nature of the flattening filter, we have the beam is not totally 100% across the field, the length of the field, and so we have some specifications that this needs to be certainly less than 2 or 3% across 80% of the field. And again, flattening filters, the design of flattening filters have improved through the years also. And there are a number of safety tests that we do. And this is done when a machine is brought in, and we do this on an annual basis. We're making sure that the exposure levels are safe outside the room. After all, the therapists are there all day, basically, whereas we're just in and out. So it matters less to us, matters a lot to them. We also want to make sure that the head leakage, in other words, the radiation coming out of once the machine hits the target, the radiation actually comes off in all directions. There is radiation that can leak through the head of the machine. And in my experience, it happened, a machine I was working on had some work done by an engineer. He was working in the head of the machine, and there's all these lead blocks, essentially. He had left one off. It's the one that was straight on. And we actually discovered that on an annual check. So there was radiation essentially pouring out of the front of the machine. That's not that important to radiation workers, but it did give all of those patients a little extra dose outside of their their treatment area. So these things can happen. We do area surveys, interlock checks, warning lights, so on and so forth. There is some recommended QA of simulators. This is more for probably a conventional simulator.
Simulator, if you guys know what that is, probably ought to eliminate that slide. We teach you conventional simulation.
There's one over in ACB. What machine is that called?
There's one right across.
Acuity.
Acusim 1 and 2.
Oh, okay.
We have a conventional simulator.
Well, these guys have probably at least seen one, I guess. And we do use it for the spine simulations, for the spine SRS simulations. So we still have one machine we have to do QA on. I don't know who's assigned that.
Yeah, Bill.
Yes. Yeah. Oh, do you? Okay. Okay. Guess it'll leave when he retires. And we still use it for the spine SRS, so a couple times a week. We also have all the measurement equipment that we use for machine QA. Also has its own QA, including the chambers that we use to measure the output. They need to be sent away. Well, actually, not too far. It's here. I'm so used to sending them out to Wisconsin. Every 2 years, an external check is performed by a calibration laboratory to make sure that the chamber is operating correctly. And actually, in my opinion, before I use a chamber, I usually like to to run a check that we usually have set up to make sure that that chamber is operating correctly. So your output checks all depend on that chamber you're using and that it's functioning correctly. So again, there's a number of other types of dose measurement devices, and there's a calibration procedure for each one of those. And a lot of these are done on a yearly basis. So I just want to mention, I think this is my last slide, the QA of the future. So we've run into a problem. There's more and more technology that's coming into the clinic, and we just really, frankly, don't have time to do all the QA. And what happens is there's more QA or more technology comes in, and we keep adding QA tasks, and we don't drop any. So, including the simulator, as you can see. So there was a QA meeting last year that was sponsored by Astro and APM, where we're going to start to think of a new paradigm for QA, which, as you can see, the TG40 is very prescriptive, right? Follow this, 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 and this. Whereas what we want to try and do is develop a systematic QA program where we're going to start to drop things that we do that we find never change. These machines have become much, much more stable. And the things that matter less, we're going to check on an even less and less basis. But we want to make sure we balance that patient safety and quality versus our available resources. So I gave a talk at an international QA meeting about 1.5 years ago, and there's a lot of, it was for the IAEA, which handles mainly developing countries. And you can imagine a developing country getting in a linear accelerator with IMRT and cone beam and all of this other stuff, and they have one physicist. And it's very, very difficult for that kind of situation, people that have less resources at their disposal to try and handle all of this, these QA tasks. So the APM has formed a task group. They've been around for a year or so, but they're taking a look at this new paradigm where there's going to be more of a risk-based approach to QA. And they're using hazard analysis, looking at broad classes of radiotherapy procedures, looking at each step, and where is the risk involved, where do there need to be more checks or less checks. And so rather than giving a prescriptive approach to places, they'll let the institutions or the hospitals choose more what fits into their situation given what resources they have.
Yeah, Mary, there was the astrophysics meeting in the fall of 2005, I believe it was. It was a very interesting paper that was presented by somebody from the UK, where they looked at various kind of risks, that you try to mitigate by doing QA, estimated the cost of the consequences of not doing QA. What's the probability that this is going to happen? What are the consequences? How much? What's the cost of the consequences versus the amount of resources required to do the QA procedure? And the bottom line of the particular paper was that sort of our standard QA procedures are cost justifiable, but it certainly provided a framework for doing this kind of risk analysis.
Right. Yes, and so this is the future. It's certainly going to be in all of your lifetime that this is going to happen. So we're looking within 10 years that the entire approach to QA is going to change. It's going to drive the regulators crazy, but because they prefer, obviously, that, you know, go through your list and check it off. As opposed to, I'm more for looking at taking an overall approach and looking at, you know, really what's important.
How long does it